My name is Scott Stretch. I'm the Chief Administrative Officer of our Cardiovascular Institute, where we have over 350 healthcare heroes that help fix over 1,000 broken hearts a day. We're on a 5-year journey to build an even better program than we have today. You'll see a lot of construction underway. We're building a 4-story tower for the cardiology clinic, the cardiothoracic surgery clinic, and the new vascular surgery clinic. We just brought on 2 new vascular surgeons to join the Institute. And then in the hospital side, we're building out 7 new cath labs, EP labs, and vascular labs. So lots of construction at the moment, but it's for a very good purpose. I want to introduce Dr. Patel. He's my partner in crime. He's the president of Desert Cardiology. He's the medical director for our echo department and many other things. And he's my partner in helping build and run the Cardiovascular Institute. And he's been the president of Desert Cardiology for many years. And that's also a very unique practice. They've been together almost 50 years. And they've only had one person leave the group for any reason other than retirement. So they really stick together and stay together. And we have 22 providers now that average 800 patients a day. So just, we're busy. And Dr. Patel.
All right, hi. Okay, there's no real like a presentation since it's completely open forum. So I'm here to answer any questions that people have. And there's 2 people walking around with floating microphones, and there's also a center microphone there. So I'll take any questions that anybody has. Okay, Candy.
Hello. Thank you.
Go ahead.
Dr. Patel, first of all, thank you for speaking to us. You did that last year, and we thought that was above and beyond. Anyway, if my question is, if you have a pacemaker and the life is less than 30%, is it possible that you get dizzy more often?
No. So that's a great question. So when the pacemaker starts to run out of battery, okay, then it still functions up until we have what's called the elective replacement interval, or ERI. So your pacemaker will continue to function until it gets to that point where we have to replace it. But even if you're in that ERI period, it still has full functionality. That actually it's built in to give you like about a 3-month buffer zone so that you can get it replaced right away. It doesn't stop functioning unless, of course, it obviously runs out of battery and you have completed that ERI period. So that usually doesn't happen. If you're having issues with feeling other symptoms while your pacemaker is in or getting close to that period, there's some other issue going on. Okay?
Yes, we're having a debate. If you have AFib and you're over 65 and you've had treatment and everything, is it safe to have the 3rd COVID shot? Mm-hmm.
Yes.
It is?
Yes.
Even with AFib?
Yes. No problem.
It doesn't cause arrhythmia?
No. Far be it from what you may hear from Dr. Google.
Yeah.
Or the other internet sources. Get your medical information from medical professionals, and you won't go wrong. Yes, sir.
Doctor, about 4 or 5 years ago, we were seeing more and more leadless pacemakers. It seems like as this 4 or 5 years have passed, there's quite a few more leadless pacemakers being installed now. Are you finding out there's just more advantages to the leadless pacemaker than originally, or
Yes.
why is that?
So the leadless pacemaker, let me just go through that. There's 2 kinds of pacemakers. There's the traditional pacemaker, which has a device that sits outside the chest under the skin, and then wires that are tunneled under the vein into the heart. Those were the traditional pacemakers. They're the large, big box that you see people walking around with. And that alone had its own issues. Primarily, the major issue were infection. If they ever got infection on the wires or anywhere, you'd have to take the entire system out. But nowadays, so then what came out were the leadless pacemakers. These pacemakers go in endovascularly through the vein in your leg. We go up into the heart and we put that device right into the right ventricle, and it stays there. And there's no wires. It's direct. It's this little small little bullet. Those were the original first generation. That was from Medtronic. The second generation now has two bullets, one that goes into the right ventricle, the other one that goes into the right atrium, and they talk to each other by Bluetooth. It's pretty cool. So that's from St. Jude or Abbott. And they just continually keep evolving in how they work and their benefit. They do have some trade-offs. The trade-off is, yes, it's beneficial because you don't have a box. Okay, so you don't have any wires, you don't have any infection risk. So patients who've had prior infections or prior endocarditis, we choose this method. Or if they have other reasons where they may get infections, we choose this method, the leadless. But the trade-off is it's less information stored, because the traditional pacemaker is a box and it has a lot of capacity for memory. So you can go back and you can look at prior events. Something may have happened last week. You can go back, it has memory. These leadless devices don't have that. So that's the trade-off. So, but I think as time goes on, they'll continue to advance as we continue with miniaturization of so many things. But we are putting them in, exactly like you said, more and more and more. It's a lot easier. They're quicker. They're faster. And patients really like it because they don't have to have this big thing here. Yeah. So if patients actually, they come to me and if they need a pacemaker, they tell me, I don't want the granny pacemaker. That's what they tell me. The granny pacemaker. Yes, ma'am. Hold on. We get the.
Hold on one sec. We have one online, sir.
Oh, okay.
Let's do that first as well. If you have bradycardia and you are asymptomatic, just a low heart rate in the 40s and 50s, is there anything you can take or do to ensure that you don't get other symptoms?
That's a great question. So there's two kinds of bradycardia. There's bradycardia, and then there's symptomatic bradycardia. So people who have slow heart rates less than 50, technical definition of bradycardia, and there's many people out there who have that. There's people who have that just because they're athletic. You know, they have very good vagal tone, they're athletic, they walk around in the 50s or even lower, and they're perfectly fine. As long as you don't have symptoms, I've had patients who have their heart rates into the 30s. And as long as they're asymptomatic, you leave them alone. But if you have symptoms of slow heart rate, and that can be myriad, many symptoms, fatigue, no energy, pain, shortness, but any symptoms, that's a class 1 indication to put in a pacemaker. So in answer to this question that you're asking, is there anything to do? Well, if you're symptomatic, then you get a pacemaker. But if you're asymptomatic, there's really nothing more you can do to bring up your heart rate. It's just how you're wired. And we don't really treat that unless you're having symptoms. Okay. Then there was a question here. So, well, everyone else is hearing you. They won't hear you. So the people online can't hear you. So 1 second. 1 second. Oh, okay. Go ahead.
Excuse me. What are your thoughts on the high sensitivity CRP test? Should you ask your cardiologist for this test?
Mm-hmm. So HSCRP, or high sensitivity C-reactive protein, is a great biomarker. I check that routinely on all of my patients. It shouldn't, in a heart situation, it shouldn't be anything higher than 2.5 to 3. When it is higher like that, then that tells you that the person is in a state of inflammation. And now that we know now that a state of inflammation is just as bad as having high cholesterol, for example. Okay. So we want to make sure that that goes down. And there's been many, many studies now that show that we want to treat that high sensitivity CRP, want to treat that state of inflammation. Unfortunately, we don't have a whole lot of things in our armamentarium to do that other than old-fashioned drugs, which we use for gout. There's a drug called colchicine. And that recently has been published as shown to be effective in lowering inflammation for patients who have a higher CRP. Now, you can have a very high CRP if you have bad arthritis. People who have other types of autoimmune diseases, they walk around with a CRP that's high and an HS-CRP that's high, say in the 30s, 40s, 50s sometimes. And there's no way you're going to get that down with just this little bit of colchicine. So we only treat the patients who are have a little bump, maybe 2, maybe 3, because we want to keep it less than 1. But if you have concomitant bad arthritis or any other issues that give you bad inflammation, that's a difficult thing to treat. We know that a state of inflammation throughout your whole body is not a good thing. So targeting why that's happening. If you have orthopedic issues, having that fixed. If you have psoriatic arthritis, take those medicines. Things like that, to combat the inflammation. Because inflammation overall is not a good thing. Even dental inflammation, we've seen, has created this. People who have very bad periodontitis, that can still give you symptomatic systemic problems.
So you're definitely recommending that you talk to your doctor about getting this test.
Yeah, I would.
Okay, thank you.
Like I said, I do this routinely on all of my patients. Okay, ma'am.
I have an excellent cardiologist who has given me medication that keeps my congestive heart failure. Okay, my life is good, but I get so very tired. What can I do perhaps to exercise the muscle of my heart so that it functions better? Or is there anything I can do?
Another great question. It may not necessarily, people feel tired for a myriad of reasons, okay? Lots of reasons to feel tired. It's not necessarily just coming from your heart. Even people who have a weak heart that's pumping poorly, usually you're treated maximally, you're on effective medicines to keep it steady. So that way you're what we would call compensated. When people have bad heart failure, a weak heart, your primary symptoms are that you can't breathe, you're short of breath. But as far as just feeling fatigued and tired and weak, that can come from lots of things. And the number one reason why people in this age range, or even anybody who feels fatigued, is poor sleep hygiene. Okay? We call that poor sleep hygiene. Many people, for whatever reason, you just don't get a good night's sleep. You wake up for lots of reasons. You may wake up to go to the restroom. You may wake up because of, say, orthopedic issues and you're turning in the bed. Many reasons. You may have a dog. So many reasons why you wake up. And if it interrupts your sleep, you may sleep. You may sleep for 8 hours, but you're not getting restful sleep. You're not getting restful sleep. And that's the thing. There was actually a very nice paper just recently published. I think it was in the New Yorker or in the Atlantic, that talked about your sleep debt, that we all have a sleep debt, and that sleep debt begins early in life and continues. And it's very hard to pay back that sleep debt. You just can't say, okay, I'm going to take a weekend off and sleep. You're not going to pay it back in 2 days. So we are all with a relatively some component of poor sleep hygiene. Very few people can get a really, really good sleep. And you have to try to do that. You have to minimize having stimulants such as coffee. People have coffee in the evening. You want things like that. You want to minimize things that make you get up and go to the bathroom in the night. Turn your water off at a certain point in time of your intake. You want to do things that can give you proper sleep so that you will feel better. Because that's the major reason why lots of people, they come to me, I'm fatigued. And we go through everything, we try to find it. Look for, are you anemic? Do you have a problem with your thyroid? Do you have any other issues? And you turn over all the rocks and you don't find anything. Common things are common. You're welcome.
Great. Let's jump to an online real quick,
Okay.
and then we'll come back. How does type 2 diabetes affect bradycardia?
Affect what?
Bradycardia.
Bradycardia. Again, you guys are fixated on bradycardia. Cool. Type 2 diabetes by itself does not affect bradycardia. Type 2 diabetes does not create conduction system disease. Type 2 diabetes actually creates more atherosclerosis and affects the arteries than it does affecting the wiring system of the heart. That being said, if you have problems in your heart arteries that supply the conduction nodules of your heart, then yes, you could have bradycardia from that. That would be kind of a stretch. But by itself, diabetes doesn't really create or cause conduction system disease. So again, if you're having bradycardia and it's symptomatic, see your doctor.
All right, thank you. So we're going to jump to another one real quick because they're tied together. Can you swim with a leaderless pacemaker? And how is it determined, or what tests can be done to determine that you need a pacemaker? It comes around to obviously swimming. What can you do with any type of pacemaker or leaderless?
Whether it's an external, like a regular traditional pacemaker or a leadless pacemaker, you can swim. We just say you have to wait. So if we put in a traditional pacemaker, we don't want you going and getting that wet for at the very minimum 3 months, sometimes 2 months. We want it to heal because we don't want any infection. But once it's healed after that time frame, go swim in the ocean, swim where you want. A leadless pacemaker, the time frame is a little shorter because again, there's no big cut here. There's only one needle poke in your leg. We still give you a time window of not to do anything or soaking. But after it's healed, after everything is healed up, there's no restrictions. The only restrictions for a pacemaker on the outside are to kind of avoid very high intensity electrical fields. So I always ask the patient, do you do any arc welding? They say no. Do you shoot with a shotgun? If the thing is here, if they do, then we put it on this side. Or if they do any work over a car alternator. So rarely they do. The old concerns about pacemakers being around microwave ovens and all those things, having it all mess up, that really doesn't happen anymore with the newer shielded pacemakers. And in fact, when you go to the airport and fly, if you have a pacemaker, the only thing we tell you is don't go in the spinny thing. Just tell the person you have a pacemaker, they'll just wand you and then go on your way.
Great, thank you. Let's jump back into in-room question. We have a mic on the stand right next to you, ma'am, if you want.
It should be on.
For people that had aortic valve replacement, let's say like X years ago, eventually they're going to have a TAVR, I would think TAVR replacement. And then the other comment would be on defibrillator pacemakers compared to 2015, what has improved since 2015?
Great question. So we have to be careful what you're asking. So people can have their aortic valve replaced by two methods. One would be a mechanical valve. That valve will last forever. You don't need to do anything about that valve other than take Coumadin for the rest of your life. But if you had a tissue valve put in the aortic position, either from bovine or a cow or porcine from a pig, those valves last traditionally, they would say 10, 15 years. We've had nowadays with the newer way that we're controlling cholesterol and everything, we've had these valves last even longer. But eventually they would probably degenerate. And if they do degenerate, then we want to replace them. So traditionally, you would have to go back in, do another sternotomy, go back in, and then take out the old valve and put in a new valve. And that's a big operation because if you've had this valve in for 10 years, you got 10 years worth of scar tissue in there. So we do it now percutaneously through the leg. So we'll do a valve in the valve. We put a valve in the valve. We don't take out the old valve. We go up the leg with the catheter on a balloon, with the valve on a balloon, get it right across to where the aortic valve is and all of that, the bad aortic valve, and push it right through and blow it up. And we basically just crush all of the old valve to the sides. It's got a cage around it. It gets crushed by that cage. And the new valve is inside the cage. It opens up very nicely. That's a valve in the valve. So TAVR is the methodology. And the TAVR can be done de novo. So say somebody just has bad aortic stenosis, okay? Previously, we would only do the TAVR procedure on the high-risk patients that were at risk for having a problem if they had it done with surgery. Then it got approved for the intermediate risk patients. Now it's approved even for the low-risk patients. So now we're pretty much doing TAVR on almost everybody, de novo, okay? And then 10, 15 years later, if they need it, we do valve-in-valve TAVR. Okay, yeah, second time around. Further, okay, say away from the aortic valve, say you have a mitral valve, an artificial mitral valve. Again, not a mechanical one, but a bioprosthetic mitral valve that was put in some years ago. And that also has now become dysfunctional, stenotic or whatever, having a problem. Same process. We can go up from the leg. This time we go across to the left side and we drop the valve into the mitral position. So we do a valve-in-valve mitral repair. Pretty neat. So that is the emerging technologies in structural heart innervations for valvular disease, and there's a lot more coming. With regards to the defibrillator issue in the question, the emerging technologies now are the subcutaneous defibrillator. Because just like we have the leadless pacemakers, the two little bullets, we also have now a subcutaneous defibrillator. This just is a smaller device that goes under the skin and near the left side of the chest and can give you the electrical energy and shock your heart. So that it avoids having that big, huge defibrillator box and a wire.
Two things to look forward to.
Coming soon to a cardiologist near you. Go ahead.
In 2019, you hear that?
Yeah, we can hear you.
Okay. In 2019, I had
A little closer.
MRI that was unrelated to any heart issue.
Uh-huh.
And one note they did make was that I had a whatever it is, a sclerotic disease of the abdominal aorta without aneurysm. My family doctor recommended statins. I did the Dr. Google thing and looked at some good websites and made a decision that I didn't want to do it. And I'm 84, going to be 85. My blood pressure is good. My cholesterol is good. Should I be taking statin?
Okay. So you have atherosclerosis. Okay. Atherosclerosis is plaque in the arterial wall. So you have an artery. All the arteries in your body, from the top of your head all the way down, have 3 layers. You have an outside fibrous layer. You have an inside smooth layer called the endothelium, and then you have a muscle layer that squeezes because the arteries squeeze all the way down. Okay. Plaque doesn't just stick on the inside of the artery. Okay. It burrows in between the inner layer and the middle layer. That's called plaque. That's atherosclerosis. Okay. Now, when that atherosclerosis affects the vessels of the brain, we call that cerebrovascular disease. When that atherosclerosis affects the heart, we call that coronary artery disease. When that atherosclerosis affects the aorta or the legs, the vessels in the legs, we call that peripheral vascular disease or PAD. But it's all the same pathophysiology. And it doesn't discriminate. Just because you have atherosclerosis here in your abdominal aorta, does it mean you have nothing here or nothing here? No. It just hasn't been found. Okay. But atherosclerosis goes everywhere. So when we find people who have atherosclerosis in any vascular bed, brain, heart, periphery, we treat them all the same. Okay. We can never get rid of atherosclerosis. Whoever will figure that out will get the Nobel Prize. All we can do is slow down its progression. Further, atherosclerosis, we know now, starts very, very early in life. There's been autopsy studies of 2-year-olds who died tragically, and looking at their aortas, they had atherosclerotic streaks in those aortas. So it starts very early in life. Some people can live a full life with it, not have any problems. Some people, if it's up here, get a stroke, here, heart attack, in the legs, claudication, gangrene, foot drops off, sort of stuff like that. So what do we do? The best way, whether it's here or here, any atherosclerosis, the best way to remember is this mnemonic that I tell patients, A, B, C, D, E. Okay? What's A? For the rest of your life, a baby aspirin. You're the person, people with atherosclerosis are the people who it's meant for. Okay? B, blood pressure control. You want to keep your blood pressure, the top number, under 135 all the time. Newer guidelines just came out saying they want it now under 130 all the time. Hard to do. C is cholesterol. It's part of the mix. We want to keep the LDL, L for lousy. That's the bad one. H is the good one. H for happy. We want that high. L is the bad one. L for lousy. Want that low. We want that less than 70. Rarely people can get that down by taking over the herbal stuff or eating. Only 25% of your cholesterol is from what you eat. The rest, or 75% are what you make, the genes you got from your parents. You see? So, I mean, you could eat cardboard all day long, but your numbers will be high if you're a producer. So that's C. Then D is diet. We want a low fat, low cholesterol diet. We like the Mediterranean diets. Those work really well. And then E is exercise. You need a good aerobic exercise program. If you do those 5 things, if you have atherosclerosis and you do those 5 things, then you can really have a good full life. So to answer to your question, regardless of what Dr. Google may have told you, you need to keep your cholesterol down. So your doctor was correct. Google was not. Yes, sir. Absolutely. Yes. It doesn't matter. You should take that with the intent that it gets your LDL number less than 70, whichever one works. Now, if you take statins and you have problems with statins, which many people do, then we have non-statins, okay? But either way, you need to have some anti-lipid therapy, something, okay? If your LDL is below 70 on your own, God bless you, brother. Good for you.
Hi.
I don't
Hello.
think so, but if it is, great, then you don't need anything. No, then you don't need to. If your LDL is lower than 70, then you're blessed. Good for you.
Let me follow up on the statin. I think we had 2 questions, it seemed. Is lipoprotein A more of a threat to heart attack or to stroke? And the second part of the question they were asking is also, if you react to a statin, what is the treatment for lipoprotein A?
Okay. So lipoprotein A, or Lp(a), has gotten a lot of press lately. It's a apolipoprotein particle that we know is associated with other atherogenic particles. So we talked about HDL, which is a good one, H for happy. We talked about LDL, which is the bad one. These are the ones we know. There are so many other atherogenic particles that we just don't know about. We do know, however, that every particle, every lipoprotein, good or bad, has an associated apoprotein stuck to it. That's just the biochemistry of it. So we've found that this other apoprotein called LPA, all right, lipoprotein A, that, when elevated, increases the person's risk for events. We've seen this when we've had patients who we treat their cholesterol properly, their LDLs are less than 70, still they have a clinical event. They'll have a heart attack, they'll have a stroke. And we say, what's going on? Why did that happen? We don't understand. And then as we tested them more and more, we found they all have these higher levels of LPA. It's very high in Asians, okay? We see this very high in the Asian community, but it's also, now we're seeing it more and more here. Unfortunately, we do not have any therapies for LPA reduction yet. That is in phase 3 clinical trials right now. There's 2 companies that have these monoclonal antibodies that would work towards it. One is Amgen, the other is Novartis. And hopefully these drugs will be coming to market soon. And then we'll finally have a way to treat LPA. But right now, since we don't, all we do is drive that LDL cholesterol as low as we can, less than 50, less than 50. Because there's no other way to reduce your clinical events. None. So that would be with LPA. Now, if you have statin intolerance, okay, and you have an elevated LPA, we'll keep trying to reduce your LDL with the non-statin drugs. Our best non-statin drug right now are called PCSK9 inhibitors. These are injections. These are monoclonal antibodies that you inject twice a month. And they work really well. They work really well. Okay.
Hi. Yeah, thank you very much first, Dr. Patel, for being here, and thank Eisenhower, great hospital. And I'm curious about something. My son is almost 50. He lives in Texas, but a few months ago, he was rushed to the hospital with elevated blood pressure, elevated heart rate, and low blood pressure. Is that normal for someone young who's 50?
Well, he could be 50 and very athletic.
He's not. He's not. He's not.
Okay. Well, then, should have a good, it should have a good workup. There's lots of reasons, like if you're exercising and all of a sudden your heart rate drops when you exercise, that could be something what we call chronotropic incompetence. And that can come from issues with the wiring of your heart or with your artery supply to the bottom part of the heart. So those are things that need to be evaluated. There were some questions over here. Go ahead.
Thank you, Dr. Patel. I had a TIA in July. And they identified 3 factors. One was age, one was history of AFib, and the other was cholesterol. Excuse me. So I have a statin intolerance, but they put me on Repatha.
Good.
And the Repatha has been miraculous in terms of reducing those numbers that we were looking to get to.
Mhm.
Is the Repatha a drug that you think, once you go on that drug, that you're going to be on it indefinitely? Or do you see other drugs coming on that might replace that, since it is the injectable every 2 weeks?
Yes, it's a great question. The real answer is you're taking the drug because you need it.
Yes.
Okay, because you had this issue and need it. So you're always going to need something
Yes.
to keep the cholesterol down.
Yes.
And if you can't take the traditional method of the statins, then you take a non-statin. There are many other non-statins, okay, but they're not all as powerful. Let me explain what Repatha actually is. Repatha is what we call a PCSK9 inhibitor. Big name. So it's such a big name, we just abbreviate it, PCSK9. So you have in your body, in your liver, you have a cell in your liver called a hepatocyte. That's where all of the breakdown of cholesterol happens, is in your liver, in this cell, okay? So you have on the top of that cell this receptor called the LDL receptor, okay? And then the LDL, the bad particles floating along, and the LDL receptor grabs it and pulls it inside the liver cell, okay? Then they break apart. And your body, your liver cell, breaks down that LDL particle with an enzyme called LDL lipase. The body also breaks down that receptor because the body wants to reuse everything, okay? It doesn't make anything go to waste. So it breaks down this LDL receptor with an enzyme called PCSK9, okay? So they have come up with these monoclonal antibodies that inhibit that enzyme. So then the receptor goes right back up, gets another one, goes right back up, gets another one, keeps doing that. It doesn't get broken down. As a result, the clearance of LDL is quite profound. And that's how they work. So there are many other ways to target LDL, but this one has been shown to be very effective and very efficient. And unfortunately, we have long-term PCSK9 inhibitors. Some patients don't want to inject twice a month. So now we have long-term ones where the doctor injects it every 6 months. You come to the office, we give you a shot, you go. That works also very nicely. It's the same class of drug, but it's a longer acting drug. So that's called Leqvio. We do that a lot. Sure.
We talked earlier about the inflammation of CRP being just as important to tamping down inflammation of that type is a statin, controlling your statins. My question is, how efficacious is homeopathic or naturopathic treatments in reducing the pathogenesis of CRP?
So a lot of things we do for patients, again, why is your CRP elevated? That's the first thing. So figuring that out, orthopedic issues, other autoimmune issues, bad dentition, that's a very big thing, periodontal disease, very big thing that a lot of people ignore that can cause inflammation. But once you find and target that, that's one thing. But what you can take over the counter that can help with reducing inflammation is turmeric. Yeah, turmeric. And that can be taken every day. It's relatively safe, provided you don't take massive quantities, but can be taken every day to help reduce it a little bit. But unless you actually reduce the nidus of why, the focus, why is it happening, you'll never get it under control. Okay. Some people who have really like bad arthritis, they're always going to have a very high number. Okay. Yes, ma'am.
I also have a very good cardiologist that like this lady in front of me. I'm very pleased over the years of the treatment. But I just wanted to tell,
Thank you.
Mr. Cardiologist, know that recently I have been, had a diagnosed with some sort of autoimmune skin disease. They don't know what it is yet because the biopsy has not come through. I also have recently been diagnosed with very low calcium. So I'm on, according to the endocrinologist, I should be taking 1,000 milligrams of calcium, 2,000, 1,000 and twice a day, which I've been doing to try to bring up the calcium. If your calcium, what level should your calcium, if it gets very low? I recently have been experiencing very large bad leg cramps and very extreme fatigue. And I wondered, they say that if your calcium gets too low, it could result in heart problems. And is there any kind of treatment for that I should be aware of that my cardiologist could do to help the blood pressure, to help the calcium stay at a level where it wouldn't be dangerous for heart problems?
So if your calcium's low, we supplement that. You know, taking oral calcium is hard to raise your blood levels with just oral calcium. That's a little challenging, but it can be done. Many people who have osteoporosis suffer from low calcium. And treatment for osteoporosis there's lots of drugs out there that they use to help bring up the calcium level. So perhaps your doctor will start giving you those types of therapies. Just taking a calcium pill really won't raise your blood level a whole lot up or down. So you need the therapies that we give people who have osteoporosis.
Osteopenia, does that mean?
Similar, it's a cousin. Osteopenia is just the beginning of it. When it gets really worse, it becomes osteoporosis. So you're having the beginnings of it. So those are the things to discuss that with your endocrinologist about the therapies for that. And these are usually injected medicines that are given to you that help to bring up the calcium level, help your bones resorb them.
But what about autoimmune breakouts, like if you have welts from?
That could be from many things. If you have an autoimmune dermatologic disorder, there are many of them, and they can come from many things. And again, it's autoimmune. That means you have the antibodies to fight something that's bothering you. And it could be anything that could trigger it. So there are many different kinds. So until you actually have a biopsy diagnosis about what you have, it's very hard to just guess how to treat that.
So are there injectable medications for those diseases too, as well as for
There are.
osteoporosis?
There are many things available for autoimmune diseases. Depends upon what you have. That's the key.
Thank you.
You're welcome.
All right, we'll jump to a couple online. How does chronic insomnia affect bradycardia, and can you take Lunesta with bradycardia?
This is very interesting. All the Zoom people are just fixated on bradycardia.
I think it's the same
It's
person.
funny at home.
She needs an appointment with you, I believe.
Okay, so insomnia affecting bradycardia can happen if you're having sleep apnea, but not necessarily insomnia. If you're awake, you're kind of awake and your heart rate's really not that slow. But in the nighttime, we have sleep disorders. If people have sleep disorders, primarily sleep apnea, that definitely can create arrhythmias. The number one arrhythmia created by sleep apnea is atrial fibrillation, not necessarily bradycardia though. So there really isn't a whole lot of correlation between insomnia, where you're heightened and awake, and then bradycardia, where your heart rate's slow. That's kind of a disconnect. When you're sleeping, when you're asleep, your heart rates are slow. When you're awake, and interactive, your heart rates are not, unless there is a problem.
Great.
Okay.
Thank you. What sort of testing is done? This is a general question, is done to check cardiovascular health on a healthy individual? Is testing done annually? What would you recommend for?
Depends on your age. Okay. So we'll just say 50 and higher. Okay. Someone comes in over the age of 50. What would I do with that person? The first thing I would assess is your history. That's the number one thing, and your family history. So if you have a history of heart disease, that's one thing, but say you're a completely healthy person, you have no family history, you have no history of heart disease yourself, then the next question is, do you have history of stroke in father or mother, history of heart attack in father or mother, any type of family history? If they do, then it's all about getting what's your risk. When I see a person in the office, the big question is, where are they in the risk of heart disease? Are they high risk? Are they intermediate risk? Or are they low risk? And that's all, again, predicated on whether or not you have plaque or atherosclerosis in your arteries. It's all about that, okay? So we endeavor to find out if you have plaque. What I do when I see the patient, I always check the carotids to see if you have plaque there. Because if you have plaque in these arteries, this is our window to your whole body. If you have plaque here, you can have plaque everywhere, you're high risk. Your risk is, or you're a high risk individual. Then I check the heart. Nowadays, we can check the heart a little bit more sophisticated because of the artificial intelligence software. We're able to actually do virtual angiograms, which is pretty cool. Before we do the virtual angiogram, we can always do it in a stepwise fashion by doing a coronary calcium score to see how much calcium you have stuck in your heart arteries. These are both CAT scans, one's without contrast, one's with. And if you do have that, then you're, again, a high-risk person. Now, that's anatomy, and I always want to couple that anatomy with physiology. The physiology is a stress test. So when someone comes to see me brand new, we want to give them a stress test to see how does the heart respond to stress. Most people can run on a treadmill. That's great. If you can't run on a treadmill, then we do a pharmacologic stress test. And then the other thing that we also do is to get a good look at the heart, kind of like the 30,000-foot view of the heart. That's the echo, the ultrasound of the heart. That looks at the heart pumping function, the valves, get an overall big picture about what's happening there. So I get those done, and then I get comprehensive blood work. I check those markers on everybody, and I check the cholesterol, and then we can risk prognosticate depending upon the data. Now, whether you do this every year, you don't. You don't do testing every year, specifically echoes or stress tests or CAT scans. You don't do them every year. You only do them if the person has symptoms. What we do is follow the person with blood work, and usually every 6 to 9 to 12 months, depending upon the frequency of how bad the person is, and assess that patient. But then if they come in and say, hey, I'm having chest pain or something like that, that's a different story. Then you expand on your testing. Okay?
Thank you.
Good afternoon, Dr. Patel. And I like the way you always check my C-reactive protein and my hematocrit every year in the labs. I came in late, so I apologize if someone already asked this question. I wanted to know about the blood-brain permeable aspects of Crestor and what's the other one? The common one, Crestor and
Lipitor.
Lipitor. Thank you.
Great.
I understand that Crestor is less permeable to the blood-brain barrier.
So that comes back to the question about statins and memory loss. Very big topic, and we see this a lot. And as we have when the patients get more and more older, a lot of times we take away the statin drug if there is some component of memory loss, because all of the statins will cross the blood-brain barrier, some more than others. Some statins are what we call hydrophilic. Some statins are what we call hydrophobic. So the high-intensity statins, such as Crestor and Lipitor, these are the high-potency statins, they cross the blood-brain barrier the most, okay? That being said, they also work the most efficaciously also. And we temper its use if we see patients are having issues with memory. I tend not to go to the high doses of statins regardless. For Lipitor, I'll rarely go higher than 40. It goes to an 80. I don't really prescribe 80. I never prescribe 80 for simvastatin. For Crestor or rosuvastatin, it goes to 40. I rarely do that. I usually will keep it at 20. So say you have that person at those doses and you don't want to go to the higher levels, and still they don't have the LDL where you want it to be, then we add secondary drugs such as non-statins, other non-statins, to help to work in concert with the statin drug to bring your LDL down. Remember, the whole idea isn't just to take a statin. Your whole idea is to take the drug to get the effect. So if you're taking the drug and you have atherosclerosis and your numbers are still in the 80s or 90s, it's not working for you. Okay, so either you have to take more to the level that you can, add something else, or try something different.
I think it's efficacious. I was just wondering if I should switch from Lipitor to Crestor, since Crestor is a hydrophilic and less permeable, so
They're-
less chances of dementia.
They're actually the same.
They
They have the same level of permeability into your brain. So that's why they work so well.
And then just another question. There's been a lot of research recently about the beta blockers in women. Did you address that already?
I didn't.
And so I had a question about that. The recent study that showed it was.
Yeah,
Would you elaborate
exactly.
on that?
And that's just the initial one that came out. So I think we need more data. That was the answer for that study that came out. Says more data is needed to know. We do know that beta blockers, whether you're a male or a female, if you have coronary artery disease, beta blocker therapy is the main therapy that we will choose. Okay, it's one of the best drugs out there to help keep your heart rate slow. So especially if you've had a heart attack. So we use it all the time, but it has its issues. Beta blockers can cause fatigue. Beta blockers can cause depression, lots of other problems. So we use each drug judiciously, and you have to look for side effects. And if they happen, you have to change them and adjust. There's no one size fits all for everybody. Yes, ma'am.
Yes, doctor. I had a question about aneurysm. What is an aneurysm and how are they treated?
An aneurysm is enlargement. And I think this will have to be our last question because it's almost 1 o'clock. So think about a water balloon. Okay. An aneurysm is usually an arterial aneurysm. And for purposes of illustration, we'll just focus on the aorta. Okay. So the aorta is basically a tube, comes off the heart. This one artery that comes off the heart goes around and goes and supplies the entire body. Okay. It branches off the heart, comes all the way down. When it's down to your pelvis, it splits to the 2 iliac arteries and supplies your legs. And every single branch off that artery supplies something. The carotid supply the brain. There's vessels that supply all of the parenchymal vessels and the lungs. There's arteries that supply all the guts, and then arteries that supply the legs and the kidneys and everything else. So this aorta, okay, can sometimes get stretchy, okay? If there's a breakdown in that middle layer, I told you it's got an outer layer that's fibrous, an inner layer that's the endothelium, but the middle layer is muscle. And if that middle layer, for some reason or another, gets broken down, it can start to enlarge. So if you have a straight tube, then you get this big enlargement and another straight. So that enlargement, that balloon, if you will, that's an aneurysm. And we have cutoffs for when that aneurysm requires surgical intervention or not, depends upon where it is and how big it is. Okay, but that's what an aneurysm is. Therapy for an aneurysm isn't always surgery. When you first detect an aneurysm, depending upon its size, if it's less than the surgical cutoff, then the therapy is keep the blood pressure and the heart rate low so you don't increase wall stress and make that balloon bigger. Okay, that's what it is. And aneurysms can be anywhere. They can be in your brain, they can be in the heart, they can be in the aorta all the way down, even in the peripheral vessels. Well, I do have to end because it is now 12:58, but I want to tell you thank you. Thank you very much for having me here.
Great. Thank you so much, Dr. Patel, and we'll let you get back to surgery and our patients. Thank you, everyone. And it is recorded, so it'll be on the site later on in about a week. So check back in, but we'll also send it out to everyone who registered. Thank you for attending.